And we are coming now to our last speaker, who my understanding is could not join us for the talk, but he has sent us the pre-recorded video. And this is Jose Banchs, who is a Senior Director of Medical Planning for Cardiac Ultrasound Imaging at Bracco Diagnostics. He joined Bracco in 2023, and his current role provides medical support to the cardiac ultrasound operations. Jose is a board-certified cardiologist with 27 years of clinical experience. He served as the director of echocardiography at the University of Texas Anderson Cancer Center for 12 years, prior to being a director of echocardiography at the University of Colorado. I'm looking forward to his talk entitled Safety of Contrast Echocardiography in a Critically Ill Patients, a retrospective study and insights for the future.
Good evening to the audience. I believe it's good evening, and I'd like to start by, in a way, apologizing for being recorded and not live. At the time of this meeting, I will be in a clinical trial site visit in person, unfortunately. And I'd like to thank the organizers, especially Gianfranco and Jerome, for inviting me and to be part of this program. I will be speaking for the next 20 minutes, I hope, in trying to respect the time. I think there's a time component. I believe I may be the last speaker, and I will be sharing with you basic information about the safety of enhancement agents, followed by a review recently published on Lumason, focused on safety in critically ill patients, and I touch up on a follow-up manuscript that came out in October of 2023 in regards to enhancement agent safety as well. As we all know, there are 3 different commercially available agents for ultrasound enhancement imaging in the market. They are different in their biological components. Our product, SonoView, is composed of 3 phospholipids, but really 2 workhorse phospholipids that we abbreviate as DSPC and DBPG. They're natural to our bodies, and a little bit of palmitic acid, mostly as a stabilizer, and an inert gas that we called sulfur hexafluoride. All agents are known to be well tolerated, and although there is obviously the possibility for serious adverse reactions with their delivery, fortunately these reactions are rare. The main difference on these agents is on the left. Optison is based out of human serum albumin, and the 2 agents on the right are dependent on polyethylene glycol. Our product has PEG, that is an excipient or basically a stabilizer in the solution, and it has a molecular weight in the 4,000 range. The agent from Lantheus has 2 phospholipids Unfortunately, one of them associated with activation of the complement system at the kidneys level, and they also have a larger PEG molecule that's attached to every single bubble. It's not an excipient like in SonoView. The paper at hand was a review that came from my colleagues in the medical and regulatory affairs of Bracco. My colleague Antonella Filipponi put together a collection of studies. These are studies that showed clinical pharmacology and hemodynamics. And the data comes from those patients that had coronary artery disease, looking mainly at the effects of QT prolongation. And there were certainly no significant differences compared to placebo. There was a cohort of pulmonary hypertension patients as well as CHF patients included, as well as patients with COPD to assess effects on O2 saturation, and patients who had pretty advanced interstitial pulmonary disease. So both, again, to assess saturation on these studies and pharmacokinetics. These are important since in the past we had believed that age enhancement agents were kind of dangerous in these disease states, and with the COPD we have disease that affects obviously the airway side, and later with pulmonary hypertension. You could see significant vascular abnormalities in these patients. And in the case of the parenchyma of the lung, obviously the diffuse interstitial pulmonary disease is compromising the lung parenchyma in these patients. So at every level of the lung organ, these conditions represented in the administration of our agent was studied to look at significant metrics. The article also includes a retrospective study that was a large volume study in critically ill patients, and also details about the post-marketing surveillance in Lumasun worldwide. These are the probably the most efficient way for me to summarize the studies that were included in this publication. In the case of the cardiac patients, the effects on ventricular repolarization were studied in a 3-way crossover study with placebo and 2 doses of Lumasun, as well as a 4-way crossover study to evaluate cardiac electrophysiology during insonation with low and then high mechanical indexes. And the evaluation was done with continuous 12-lead ECGs from 3 hours pre-dose to 12 hours post-dose, following the administration of the study agent. And then the results in all the arms compared is that there was no detrimental effects of Lumasun on any cardiac electrophysiology metrics there. The patient with pulmonary hypertension and CHF patients come from a single center randomized placebo-controlled study looking at hemodynamics. The evaluation focused on measures of PDR, mean pulmonary arterial pressure, wedge pressure monitored by right heart cath, pre-dose up to 10-minute post-dose. And again, on this cohort, there was no significant effects of on the pulmonary hemodynamics with Lumasun use versus placebo between doses that range at 2 and then 4 mLs. More on the lung side, the patient with the COPD was, again, a single center, single blind crossover, placebo controlled using 4 ml bolus and the metrics were focused on FVC, FEV1, and the mid-range of FEVF, measured at time points up to 5 hours post-dose. In this cohort, there was no effect with Lumason on any pulmonary function test, O2 sats, ECG, or lab test. On the case of the diffuse interstitial pulmonary fibrosis patients, these were pretty advanced on their disease, but it was a single-center phase 1 study evaluating pharmacokinetics and safety, and looked at saturation through 1 hour post-dose. And again, no changes or clinically meaningful trends observed in the saturation or any other significant safety parameters. Just the bubble indicating that, it was really focused too on pharmacology, mainly pharmacokinetics and pharmacodynamics, all these studies. This is sort of a representative graph on the cohort from pulmonary hypertension patients. Not a big study, but again, significantly ill patients with pulmonary hypertension disease, and the group below 25 millimeters of mercury. You can see there was no significant changes, and this was reproduced even with Lumason. On the Lumason side, the pressure is obviously higher, but there was no significant difference through the time. After minutes of injection, you can see here the sequence from 7 minutes post, excuse me, on the placebo side, and 1 to 10 minutes post on the with the use of Lumason. And on the effects by pulmonary vascular resistance, again, the same. You can see the same little jump in the pulmonary hypertension side with the placebo and Lumason. So no clinically relevant or significant effects on pulmonary hemodynamic parameters on this small study. Another small study that focused on heart failure patients known to have severe LV dysfunction, looked at changes with mainly here on, as you can tell, on right atrial pressure, mean pulmonary artery pressure, pulmonary capillary wedge pressure, as well as SVR and PVR. And you can see from the black and white columns that with a dose of Sonovy 4 mL, there was no significant differences on these very ill patients as well. On the totality of the critically ill patients, retrospective observational multi-center study, there was 13 sites in the EU, followed by 9 years. A 48-hour mortality comparison was performed among patients who had echo with or without Lumason. A large number of patients, and the significant finding really is that there was a propensity score matching applied 1-to-1, looking at the death, and there was no significant differences noted between the contrast and the control group. All-cause mortality was looked at with propensity score matching, 1-to-1 with Lumason, 1-to-1 with Definity, and Optison. This is data from an FDA advisory committee meeting in 2011. And there was the findings did not show any significant differences between the enhanced and unenhanced echoes in terms of odds ratios. There is, as you can see, the enhanced echoes again showing a little bit of the group on the enhanced echoes show a little bit of diminished percentage of all-cause mortality. This is something that's been observed in other studies as well. Mainly the claims-based study by Mike Main in the late 2000s, where you can see the patients that received a non-enhanced echo, having a little bit of mortality benefit. Not really that the test, is therapeutic or anything, but it's what comes with being tested further, and perhaps the magnitude of care that is involved in these patients that we go the extra mile and use enhancement for. Also, the data from post-marketing surveillance, including 22 years of market use since from 2001 to February 2023 was included, where approximately 30 million patients were exposed, and the reporting rate for a serious adverse event here close to the 1 in 10,000, and serious hypersensitivity a little bit under that, as you can see from these numbers. This was followed by an interesting publication that came from the Mayo Group in October of 2023 that looked at the prospectively acquired but retrospectively analyzed data from the Mayo Stress Lab center, and then the collection of transthoracic studies from the Viera Health, Northwell Health, and Wellstar Health systems. They looked at reactions rates following the use of enhancement, and reported a higher rate of severe and critical cardiopulmonary reactions with the use of Lumason. And they also suggested a possible link with the at the time that correlates with the time of the massive vaccine with the theory that this could be related to the presence of PEG in the product. And of course, the mRNA vaccines have been shown to increase the immune presence of IgG, IgM post injection of the vaccination towards PEG, since these vaccines also are manufactured with PEG as a stabilizer. And so I will discuss some issues we have, obviously, with this publication from the standpoint of the formal Bracco response to this publication. There are a few highlights that I need to make clear. This publication, in the case of the transthoracic studies, not the stress data, included only a fraction of the hospitals that were using the product. They don't have the full denominator. In fairness, there they only reported from a minority of the hospital that had one or more adverse events, and we know from the product sales and delivery that this was really an incomplete count of the institutions that actually were using Lumason during that period of time. Obviously, there are the standard limitations that you can see here that come with the retrospective study and the way data from retrospective analysis are entered into clinical databases. There's also, well discussed in the paper, that there's limitations when it comes to the classification of these reactions based on the timing of them, if they're really collected between the first 30 minutes of contrast administration, if it's really more a CARPA type of reaction where there's usually no immune system response. It is more of a complement activation response, and these are a little bit more unpredictable. And we know from the literature that these are indeed the large majority of the reactions that occur with enhancement administration as well. There's also mention on the paper itself that the frequency of these adverse events may have underestimated. This is possibly more likely with the competition agent because this was the agent that's been used in the institutions for longer periods of time. So there's much more familiarity with the other agent. Also, they declared that back pain or headache were not to be allergic and was not a major focus. And obviously, this is particularly back pain, a notorious effect of DEFINITY. Depending on the literature, the population, you see this reported in 10, maybe even up to 20% of the time, especially in the populations that are either identify arthritic or sickle cell patients. The other big highlight is that, to point out is that there is a different administration schemes, and this is a major confounding factor for the patients with that, were given Lumason in these institutions. It was always a bolus, a standard dilution. And DEFINITY in some places was given as a dilution or a further dilution as it's detailed in their package insert. In particularly the Mayo Clinic stress echo database is not a apple-to-apple comparison because the large majority of these patients are given a different type of stress challenges. And so the data, as they reported, you can see the bigger numbers are really here on the Mayo side, and then whereas mostly stress, and on the non-stress institutions, the bigger numbers come from an institution that actually didn't even compare against DEFINITY. They just reported Lumason use, which is also kind of interesting and perhaps not a irregular way of reporting from a retrospective study. The larger numbers that came from the stress database from the Mayo only included 11,500 Lumason administrations. DEFINITY was more than double of that. And you can see here what I was alluding to earlier. The large majority of these patients were destined for the treadmill. And on the DEFINITY column, these were a large majority of them destined to be tested with dobutamine or challenged with just dobutamine. And so there were significant statistical differences in things that catch your eye. In particular, the fact that the Lumason column patients, they had less incidence of hypertension, much less incidence of diabetes, significantly less incidence of history of an MI or intervention, both percutaneous or surgical. For revascularization, they had slightly better ejection fraction, better mass index measures, much better in terms of diastolic function parameters or metrics, and much better in regional wall motion abnormality. So not truly, again, an apple-to-apple comparison. I also have to point out certain things that catch my eye. For example, these list of the signs and symptoms that they categorize do kind of make me question certain things. For example, the things like adjudicating more shortness of breath to patients that are on the treadmill. Well, some of that obviously to be expected. I'm really curious too about the ST elevation because they all happen in these patients that we already knew had less incidence of the worst risk factors, better diastolic function, etc. And yet something as specific as ST elevation was only seen in this group of patients. So that happens to be, again, a very specific and not a common finding during exercise stress echo, as we know. And this study, for example, had two groups, small groups, but still these all group one, all patients with known anterior MI. In the absence of a luminal narrowing 75% or more. Group 2, 36 patients who have predominantly angina, but did have a proven or known luminal narrowing of 90% or more in the LAD. And as you can tell, the incidence of ST elevation here is perfect. I mean, all of them, and here 93%. So really accentuates that this is a extremely specific sign, the XT segment elevation. So again, very unusual to see that on the healthy column. These patients who, again, they knew statistically different, had more benefits in terms of less hypertension, less diabetes, less history in MI. So very sort of an inconsistent thing to have picked up here. And very soon we'll have data from the upcoming AHA meeting, and the group from there's a group of investigators led by Jordan Strom from the Harvard system that actually conducted a very large claims-based analysis, starting with 11 million patients, but analyzing 500,000 that receive enhancement. And in his case, he was able to do propensity score matching and do a comparison of events that included death or anaphylaxis, myocardial infarction, ventricular tachycardia, or arrest. And as you can see from the numbers on the purple table here, the data that included from the beginning of 2018 to the end of 2022, obviously a period also encompassing the COVID-19 vaccination, the results really found that there was no difference in these events across the agents and during those years of study. So kind of tampers and or really goes against what the previous manuscript had just showed. Obviously more to come. This is just an abstract that I caught to be pressed, that will be presented at the AHA meeting coming up in the next week. But the story is still not really clear, and of course we're really following this very closely, particularly when it comes down to the COVID-19 theory, because if that is really true, hopefully further studies will be confirmatory. But also it would apply to other IV medications that are pegulated, like certain antibiotics, certain formulations of doxorubicin, and amphotericin, for example. So this will not be exclusive to PEG containing agents. So more to come, obviously, from the literature about this in the near future. Regardless, the warning against allergy or reactions to polyethylene glycol containing agents was already, the alarm for that was sound already in the past. This guideline statement, consensus statement from the American Society of Echo came out in 2021, alerting labs to be ready for this kind of potential reactions against PEG. And the big message is, that we should recognize these type of reactions, including CARPA reactions, and then be ready with the appropriate therapeutic equipment and doses. The personnel basically in our labs have to be trained for early recognition and early treatment of these reactions. And I think that this is my last slide. In general, I want to, convey that Lumason obviously has established a safety profile. The recent retrospective study reference, it may be thought-provoking, but mainly it's a good reminder of the reality of enhancement use and the possibility of clinical issues that we all need to be prepared for. And unfortunately, no prospective safety trial has been conducted yet, and more is to be learned about the possibility of PEG-based reactions with this COVID vaccination theory. But we're still early in that process of learning from that, and we're very interested in what comes out of that in the studies in the future. Again, thank you, everybody, for their time and attention. I believe this QR code leads to my contact information, email, etc. And I'll welcome those of you who want to write me and get more detailed information on any particular things covered here. Thank you again very much, and have a good rest of your day.
Thank you. Thank you very much for Jose's talk. I think it was very enlightening to see where we are now with the safety issues with the ultrasonic contrast agents in general used in cardiac diagnostics. It's lots of different results that he has shown. Certainly, we are talking about because unfortunately, Jose, I was told, cannot join us. I'm just trying to preempt the thoughts that might come to us. Is that the results are all coming from a retrospective data analysis and comparison. What I would take home as a message that there is no major safety issues using ultrasonic contrast agent with any of the types that we are having, especially in the benefit for our patients, appropriate diagnostics. And that's why I think one of his slides showed that there was a survival benefit or mortality reduction in critically ill patients who had been investigated using a contrast agent. I assume they had an echocardiogram at the time when they were in critical care units, clearly due to the more accurate and precise diagnosis of left ventricle functions or any other issues that had to be answered by the usage of contrast. What really strikes me is this PEG-based reactions and the CARPA reaction caused by or nearby the vaccinations by the of the COVID vaccines. And had Jose been around, I would have asked him of what safety he can give us in how far after the COVID vaccinations are patients safe to undergo, for example, a contrast injections or stress echocardiogram, because that has got the practical issues in our clinical practice. Of course, COVID is not as of a mortality-driven entity anymore as it was in 2021, but we still have got plenty of COVID patients and also patients who undergo vaccination at their choice. So I'm not sure whether we have got the panelist equipped with this answer of saying that, how safe it would be or how long to wait after a COVID vaccination or COVID infection if we were to use contrast in these patients to minimize this very rare reaction of the PEG-based CARPA reactions, because that would have a practical issues for all of us. I don't know who to put this question. It's more an interesting thought to clarify. Jose clearly would have answered this for us, but I think this will hang into the air for maybe him to come back to us and put it in the webinar as the important clinical value of his safety and in critical care patients talk. Beyond that, I'm just wondering whether we could just both Harald and Paul just give their opinion of how do we feel what will be if we had a genie who could fulfill our request in no time? For the future, what would we like to have to enhance the diagnostic accuracy and the patient's benefit of a ultrasound contrast agents predominantly used during stress echo settings? And I can put it to Harald and Paul probably just to play with this idea of what do you foresee in the future would really be very useful for both clinical point of view as well as a diagnostic point of view to help the workflow and efficiency in the healthcare system that is really trapped with cash, and everybody is moving towards efficiency increments.
I think you have had it in the webinar, and I think it's the combination of an optimal recording, which there are also ways to improve that, where we're working on, and then having AI to assist us. And so I'm very excited about Paul's results, and I think that's the way forward. So what we would do is, and what is also the future in other diagnostic areas in imaging, that we use also AI. And Paul mentioned how this is not much delay to get the AI result, and then you still look at it. And I think that still will be necessary in the future. But having, you see, otherwise we need a second opinion, but AI can be the second opinion. And I think that's the next thing which should come.
Yeah. I think for Paul as well.
Add to that in terms of comments, I think what was really been highlighted by the session today is it's actually technically we're very good at performing, the technical requirements for stress echo are very good. So the ultrasound machinery has improved, and the quality of the images being generated by the ultrasound machinery has improved. The use of contrast is providing really good delineation of the LV. I think one of the areas which we need to still keep focusing on is the operator and how they're acquiring the images, and how it highlighted the importance of how you get the proper training new generations of operators to do stress echo. Really important based on the importance of the guidelines. We need to bring forward more junior staff members training stress echo, because it is a nice accurate test. And I think that's where the AI probably potentially fits in, is helping with the interpretation and the operator element of the stress echo. Technically, getting the images with the delineation is very nicely refined now, and with good quality and high contrast use, you get really nice results. And I think the AI is going to come in to support that operator in terms of both training and then maintaining consistency of the reporting of the stress echoes.
Excellent. And I think with that, we can just maybe have a one-sentence summary that with this webinar, with the beautiful talks that we have heard, we can safely conclude that using ultrasonic contrast agent continues to be with us, especially if you want to improve the quality of the transthoracic images for our patients, both diagnostics and prediction of the long-term and short-term outcome. Contrast agents are clearly safe, and we have got, I think, between three of us, we have got at least probably 25, 30,000 cases that we have done over our lifespan in stress echoes. We don't see a huge amount of adverse reactions, certainly not serious adverse reactions. But these COVID-related PAG CARPAs are important for us, and we just have to get to the bottom of that. There will be some future data coming out, I'm almost certain about this. So with that, I'm really grateful for both Harald, Paul, as well as Gianfranco and Jose to join us today and get this very important and enlightening webinar. And we are also grateful for the audience who persevered with us. We have got probably up to 100 plus live audience that joined us today. and of course Bracco, who pulled this up and allowed us to bring this knowledge to the audience to enhance our patients' care long term. That's from my side. Thanks very much. Gianfranco, if you wish to close, or Jerome.
Jerome, please.
Yeah, thank you, everyone. And I think it was a great, really a great session tonight. For sure, there are plenty of questions that still need to be answered. Well, you've seen that we are working on this. Bracco is working hard on this. You are all contributing to the progress of this wonderful procedure. And thanks to all of you, thanks to Bracco, and thanks to the audience. We wish you a very good night.